delivered by speakers who are renowned in their fields, and I hope all of us had an opportunity to learn from them. So the program for today would be that initially, first there would be a recap of the day 5, and after that we are honored that Professor Mrinal Kanti Das, who's the president of CSI, and another very senior Professor Santanu Guha, they have joined us, and they are going to give a recap of the whole. After that, it will be today's rest of the meeting for the day. So let me hand it over for the day. Gentlemen, all yours.
Okay, may I start?
Yes, please go ahead. No, Bhagirath?
Yes, sir.
You have to start.
I'll start. Okay.
You and Vishal and Dr. Prakash Negi should take over the conference, the meeting.
Dr. Bhagirath, may I request you to tell us about the recap of the last meeting, please?
Yes. Thank you, sir. A quick recap of the session 5 in the week gone by, that is 22nd July. So there were 4 talks, and I'll do my best to give you a summary of the talks as well as a brief part of the discussion in the next 10 minutes. So the first talk was by me. It was on mechanical circulatory support in heart failure. So I spoke about mechanical circulatory support being broadly divided into temporary as well as durable. If you see the slide, there is a faded intermediate category given between. And this is because though the guidelines say that temporary being 6 hours to 1 week and durable being 1 year and beyond, there is now an intermediate category which is for 6 hours to 1 year. The decision to put mechanical circulatory support is beautifully shown by the pyramid, the sky pyramid as it's now known. Cardiogenic shock is divided into A, B, C, D, and E categories. So the C, D, E categories are the categories which are worse off and require mechanical circulatory support at the earliest. I spoke about the accepted indications for temporary mechanical circulatory support. Basically, these are the features of cardiogenic shock, CVP more than 20, cardiac index less than 1.8, cardiogenic shock or a post-cardiac arrest, blood pressure less than 80 on 2 inotropes, post-MI VSR, and fulminant myocarditis, and other similar conditions. Contraindications are if you have a patient who's had a cardiac arrest and you're not sure of the neurological status, EEG is not contributory, then you might as well hold on. Or if the patient has disseminated malignancy, thrombocytopenia, and so on. I spoke about the various temporary mechanical circulatory devices that are currently available with us and spoke in detail about each one of them. I also spoke about the intermediate category, which is typified by the CentriMag device. It is basically indicated in those patients who where they cannot be weaned off cardiopulmonary bypass. It is indicated for circulatory support up to 30 days. It is licensed for use in post-cardiotomy situations, bridge to recovery, bridge to candidacy, and as well as destination therapy. You want to see if the patient's a good candidate for long-term LVAD support, then you have to try him first on a CentriMag. And also in patients with cardiogenic shock due to acute RV failure, we also use CentriMag in an LVAD situation where the RV starts failing and you want to support the RV, which may take as long as 30 days. Next is the accepted guidelines indications for durable mechanical circulatory support. This is patients with NYHA class 3B to 4, LV ejection fraction less than 25, any one of the following: intermax 2 to 4, inotrope dependence, progressive end organ dysfunction, peak VO2 less than 12, or temporary MCS dependence. All of them are class 2A, level of evidence B. It can also be considered, that is durable MCS in class 3B to 4 NYHA, EF less than 25. If you want to reverse the PVR, if the PVR is initially high, you want to see if you can reverse the PVR before transplant, or if the patient has reversible renal failure, and also for certain reversible forms of cancer, obesity, and so on. There are also certain contraindications which I spoke about, which basically is sepsis, bacterial and fungal infection, and if there's irreversible neurological damage. I spoke about generations of VADs, starting from generation 1 to 5, and I also spoke about the fully implantable LVAD. Lastly, I spoke about the indications for an artificial heart, basically severe biventricular failure, allograft failure, if there's a cardiac rupture where you can't get a donor heart available, decompensated right heart failure due to on a patient on LVAD support, or if there is recurrent arrhythmias. So this much was from me. And next talk was by Dr. Chopra on the heart failure standard of care in 2020. The various trials, the entire 2 decades trials, 2001 to 2020, has been summarized in this chart. And basically, the focus was on paradigm heart failure and DAPA-HF. These are the 2 trials that have captured the imagination of clinicians world over because of the immense potential that they carry. This is the basic foundational therapy: ACE inhibitors, ARBs, beta blockers, MRA, and of course the choice that we now have. And basically the focus was on neprilysin inhibitor as well as SGLT2, apart from vericiguat and ivabradine. So a single snapshot from paradigm heart failure trial. Obviously, all of us know this. This is the comparison between enalapril and sacubitril valsartan. Death from cardiovascular causes or first hospitalization. Clearly, you can see the graphs, the Kaplan-Meier scales are separating right at the very beginning. And also the DAPA-HF trial, which again compared placebo versus DAPA, that is cardiovascular death and worsening heart failure event. Clearly, again, the graphs are widely split right from the very beginning. So this is the summary of worsening heart failure events as typified in the DAPA-HF trial. And this is highlighted in the circle that I've shown. Particularly, we have a favorable effect and outcome in terms of cardiovascular death, hospitalization, urgent heart failure visit, or cardiovascular death and hospitalization. All of these parameters are compared. And this is a snapshot of the 2 biggest trials in recent times, paradigm heart failure trial and the DAPA-HF trial. So then the main question that was addressed is the benefit of dapagliflozin additive to sacubitril and valsartan? So we now have data coming in regarding this, and this is a snapshot from McMurray et al. In NEGM 2019. And then we have a nice paper by Muthaiya Vaduganathan. This is an online publication that which looked at a comparative analysis of 3 randomized trials, and then you have the data that is here. They were divided into 2 arms: conventional, that is RAS blocker and beta blocker, and comprehensive RAS blocker, beta blocker, and neprilysin inhibitor, MRA, and SGLT2 inhibitors. So clearly, the verdict is clear that the comprehensive approach, wherein all of them are included, definitely has a big advantage. We need more data, and this is definitely the way forward. Next, we had a talk by Dr. Ajay Bahel on valvular heart disease and heart failure. So Dr. Bahel spoke, first of all, for the clinicians in this group regarding the mitral stenosis and Austin Flint murmur, how to differentiate between the 2 groups. So these were the various differences that were discussed. And also for the sake of the postgraduate students who are on board, including the amyl nitrate difference. Next is regarding the severity of mitral regurgitation in the presence of severe aortic regurgitation. We all know that it's difficult. So you have to use the left ventricular S3 as a possible guide, as also the widely split S2. The next big focus was on tricuspid regurgitation. This is often underrated, but often is one of the leading causes of death among all patients with valvular heart disease. Surgical treatment continues to be a nightmare even in the best of centers, and this particular valve carries the highest death rates when you look at cardiology procedures. And many patients do not receive effective therapy for tricuspid valve disease. Most of it, 90% is functional. There is also hypertensive TR. There is often left heart valvular involvement, that is mitral, aortic, and left heart disease, and particularly pulmonary hypertension. We all know that with time, there is negative remodeling of RV rather than the valve problem, which contributes to more and more TR. And this is a vicious cycle where TR begets TR. The surgical management of tricuspid valve disease was discussed in great detail. The three categories: primary TR, tricuspid valve disease in patients undergoing left heart surgery, and isolated late or functional TR. This is a snapshot of the results. If you look at primary TR alone, mortality rate is high, 4 to 17%, especially in older patients and those who are very symptomatic and with RV dysfunction. If you look at isolated tricuspid valve surgery, this is another nightmare. Almost a quarter of the patients don't make it in this category. Percutaneous interventions, this is the light on the horizon. We have numerous devices, coaptation devices, annuloplasty devices, cable valve implantation devices, transcatheter tricuspid valve replacement, and for patients who are high risk and fairly low rate of periparietal complications and death, percutaneous interventions is probably the way forward. However, there are now at present some concerns regarding the efficacy of such devices. Suffice to say that probably if it is fairly, we have enough experience in this, then this would probably be the way forward, because right now surgery has a prohibitively high mortality rate. And of course, we don't know, we don't have data on long-term clinical outcomes. So we'll have to wait and watch. Finally, Dr. Bahl spoke about the immortal benzathine penicillin regarding the various dosage regimens. So this is a snapshot of the various protocols that are followed. Suffice to say that you have two categories, 30 kgs and below, and above 30 kgs, and who gets what dosage of benzathine penicillin. A good thing is that you don't have to alter the dose in renal or hepatic impairment. The next big question is how long to give it. Do you give it lifelong, or you have or 40 years or longer? And you have data from various studies that are given in this particular slide. The last part of the session 5 was two wonderful cases by Dr. Anup George Alex. The first case that was discussed is a 33-year-old lady, rheumatic heart disease, postpartum 45 days, full-term normal delivery, evidence of heart failure, NYHA class 4 with orthopnea, low-grade fever. The important investigation in the current scenario, she was COVID negative, no history of any reduced urine output or palpitations, non-compliant to medications during pregnancy, echo, mitral valve orifice area is 1.4 centimeters squared, and normal LV function. So the various differentials that were discussed in this particular patient is peripartum cardiomyopathy, rheumatic reactivation, or viral myocarditis. And after discussion, we arrived at peripartum cardiomyopathy as the most possible diagnosis. We then discussed on the guideline-directed medications for peripartum cardiomyopathy. And the next issue, how long should we continue, whether it should be till the ventricle function recovers or lifelong. Consensus is that we should continue for as long as possible. The next problem is patient also had mitral valve disease. So should you do the BMB now, or should you wait for some more time? Consensus was to wait for some time. And of course, most important advice is no more pregnancies. The second case is a 73-year-old diabetic and hypertensive patient with worsening dyspnea and an episode of syncope. Patient was diagnosed to have inferior wall and posterior wall and RVMI in 2019. Left main with triple vessel disease, left MCA infarct, severe LV dysfunction, acute renal insufficiency, and referred for CABG, but was advised OMT in view of high risk. So the various diagnoses in this patient was discussed. Most important being low flow, low gradient aortic stenosis. How do you manage? This patient had that condition. Apart from that, you also have numerous other problems like left main with triple vessel disease, LV dysfunction, atrial fibrillation, class 4 heart failure, diabetic and hypertensive, old CVA, chronic kidney disease, and hypothyroidism. So this is a snapshot, and this is how the flow chart is for low flow, low gradient aortic stenosis. The approach to treatment again was discussed. Would you do balloon aortic valvuloplasty, or would you take this patient for left main to LAD PCI under the cover of Impella or an IABP support, or would you do TAVI? And the consensus was probably if the patient worsened, we would probably do BAV and stage it, look to stabilize your patient, and then proceed. Thank you, everybody.
Thank you for that wonderful recap. Now I'd request my co-moderator, Dr. PC Negi to please invite the next speakers who will recap the entire course so far. Dr. Negi, you need to unmute yourself, please.
Dr. Negi, you are muted. Please unmute yourself.
In the interest of time, may I request Dr. Vishal? Okay, Dr. Negi is back.
Am I audible?
Yes.
Yes, go ahead. Hello. Now I invite Renal Kantidas to summarize the all the topics we covered during the last 5 days and give us the take-home messages. Renal Kantidas, please.
Yes. Good evening, everyone. I am delighted that this kind of teaching program has been started with the virtual platform, and really I am honored to present before you some of the highlights. Professor Santanu Guha will follow me after I finish some of the topics. Our main focus will be some of the the important bullet points, and the first disease that was discussed was on the iron deficiency anemia in heart failure, and this was discussed in detail about how to diagnose, how to go for the various tests, and as you have been highlighted about this, that there are basically two types of the iron deficiency anemia. One is the absolute iron deficiency, and the other is the functional iron deficiency. And both of these diseases can be more found in the higher group of NYHA classification in class 3 and class 4. And it's not specific to any particular country. It can be there in any country, USA, Europe, Singapore, but it has been more detected in the Indians because of obvious factor that we have more of iron deficiency anemia in our population. And also there has been discussion on the various treatment modules, but one of the important highlights was the medication with ferrous maltose, because oral iron therapy actually does not work in this anemia in heart failure, unlike in other kinds of heart iron deficiency anemia. So this must be remembered, and this iron therapy, intravenous iron therapy, actually gives salutary results. In fact, they correct not only the anemia but also improves the heart failure condition. The next disease that was talked about by Dr. Hari Krishnan was the impact on health system of heart failure, and also its impact on the society. And he was mostly focusing on the heart failure with mid-range ejection fraction. This is the middle child of heart failure, and classification. As you know, that the mortality is very high in heart failure. In fact, it is more than the even the cancer, some of the cancer, especially the breast cancer, which is very much highlighted, but not the heart failure. But heart failure has got more, the mortality. But there are, as you know, the three classifications which have been highlighted by in the form of the heart failure with the reduced ejection fraction, with preserved ejection fraction, and the third child is the middle child is the middle range ejection fraction. Basically, there is a sort of a continuum in the ejection fraction, and that results in mid-range ejection fraction. They more or less manifest with the diseases both in the reduced ejection fraction as well as the preserved ejection fraction. But ultimately, the symptomatology is almost same, and clinical findings are almost same. Only the echocardiographic finding, they differentiate between the two. And it's a huge burden affecting the health system and also the, exchequer, and it affects younger ages with, of course, high mortality, in between mortality between the preserved ejection fraction and reduced ejection fraction. And there are evidence-based management which can be of use for reducing the mortality. Accessibility, availability, and affordability are also issues. And prevention is the key focus, because most of the risk factors or comorbidities which are responsible for this mid-range ejection fraction must be taken care of, and that actually prevents the development of the acute heart failure and chronic heart failure in tandem. Now, so for the pathophysiology of heart failure with preserved ejection fraction versus RAF was discussed by Dr. B.K.S. Sastry, and this is very, very interesting that the focus on the HEP-RAF actually is more on the remodeling side. That is, there is more on the side of the hypertrophy, which is concentric hypertrophy, which is actually mediated by transduction, transcription of the different genes, and mediated by, of course, the microvascular inflammation, endothelial activation, collagen synthesis, and ultimately there is also the concentric left ventricular hypertrophy with microvascular ischemia. Vis-a-vis in the HEP-RAF, there is definitely endothelial dysfunction with collagenesis, but this hypertrophy here is the eccentric hypertrophy, and there is more of myocardial injury and also stimulation of the neuroendocrine activation. And this neuroendocrine activation not only is related to the RAS, but there is the very much talked about system, that is the neprilysin system, which actually is activated, and that results in more deleterious effect. And naturally, the treatment focus should be more on this neprilysin system as well. And then Dr. Ambujrai discussed about the peripartum cardiomyopathy, and I'm not discussing all the points, but definitely medications used in treating heart failure during pregnancy and lactation require special consideration. And severe heart failure may require advanced therapy and mechanical circulatory support. Then subsequent pregnancies carry risk and risk of relapse, and dedicated counseling and monitoring are essential. And future research are very much essential, because the treatment is not uniform all across the globe. It is, say, for example, the bromocriptine is very much used in the Western countries as well as in South Africa, but not so much in our countries. But definitely, this was discussed that the bromocriptine may be the sheet anchor treatment in case of PPCM. And apart from this, the oral heart failure drugs, anticoagulation, relaxants, and diuretics are to be taken into account. And bromocriptine to be used as per the ejection fraction level. If it is more than 25%, then it can be used for 7 days. If it is less than 25%, it can be used for 14 days. And in case of the very much critical patient who are in shock, then you are to start the bromocriptine, and along with these, actually, you are to take care of with all other anti-failure agents, which are the pillars of heart failure treatment. Now, so for the hypertrophic cardiomyopathy is concerned with heart failure, Dr. Sanjay Mittal highlighted it in a very detailed way, and definitely is the heart failure in hypertrophic cardiomyopathy is a multifactorial disease, and it's quite common. And HEP-RAF is the more common manifestation, along with heart failure with mid-range ejection fraction. And RAF is much less, only in advanced cases this can happen. And heart failure with HCM is of bad prognosis, and medical therapy has less definitive role. Atrial fibrillation is very much important, which is of great concern, and one must take care of that. And heart failure onset increases the risk of sudden cardiac death. And LVOT obstruction is very, very important. And there has been a sort of algorithm where the LVOT obstruction can be taken care of by either the ablation therapy and or myomectomy. And these are based on the various findings, and all these have been discussed. And so for the chronic heart failure is concerned, in heart failure in hypertrophic cardiomyopathy, one will have to go with the basic management of the chronic heart failure. And if the hypertrophy is very much prominent, then definitely the therapeutic action will have to be targeted to the hypertrophic myocardium, either in the form of surgical therapy or alcohol ablation. And of course, there is a role of ICD also to prevent the sudden cardiac death. So with this, I stop here and I hand over the charge to Dr. Santanu Guha, who will present his deliberation.
So please unmute yourself. Dr. Guha, sir, please unmute yourself.
Yeah. Dr. Das, please share your screen, because I can speak from here itself. You share the screen. Yeah. Firstly, the arrhythmia-induced cardiomyopathy was taken up by Dr. Rakesh Yadav from All India Institute. The highlights are, there are several triggers for a reversible dilated cardiomyopathy like tachycardia, the atrial fibrillation with fast ventricular rate, and PVCs. Many people are not aware that PVCs, if they're high in volume, can trigger and can produce a dilated cardiomyopathy-like state. Arrhythmia-induced cardiomyopathy should be suspected in patients without an obvious etiology. Obviously, an ambulatory ECG monitoring is key to screen and properly diagnose arrhythmia-induced cardiomyopathy. There should be either lots of tachycardia, or if it is PVC-induced, there should be a high volume of PVCs. Reversal of cardiomyopathy by elimination of arrhythmia not only confirms the diagnosis, but may significantly improve the outcomes. Next one. Dr. Justin Paul took up the chemotherapy-induced cardiomyopathy, or CHIC. It is one of the common manifestations is the development of LV dysfunction and overt heart failure. According to the definition proposed by the Cancer Review and Evaluation Committee, LV dysfunction is characterized by a decrease in LV ejection fraction that is either global or more severe in the septum. There should be symptoms of congestive heart failure, associated signs of congestive heart failure, including but not limited to S3 gallop or tachycardia or both. And there should be a decline in LV ejection fraction of at least 5% to below 55% with accompanying signs or symptoms of CHF, or a decline in LVEF of at least 10% to below 55% without accompanying signs and symptoms. The several drugs which can produce an cardiac toxicity has been enumerated and discussed. Next. There are several comorbidities associated with heart failure, and Dr. Abraham Oman, he discussed the sleep disorders, iron deficiency, depression, and obesity. Comorbidities are particularly important for the quality of life. There are several sleep disorders like obstructive sleep apnea, which can get improved with CPAP. The central sleep apnea occurs in a later stage, and one should avoid adaptive servoventilation. Obesity often coexists with heart failure, and there is an obesity paradox. I shall come to that a little later. Iron deficiency and anemia has already been highlighted, and it should be evaluated and treated in all patients of HFrEF. depression is far more common than we consider it. In obesity paradox is not applicable to HFpEF patients. It is an independent risk. Obesity is an independent risk factor for developing heart failure. But once heart failure is diagnosed, obesity is associated with lower mortality across a wide spectrum of BMI. This is the obesity paradox. This apparent protective effect of adiposity tends to disappear at a more extreme levels of obesity. Next. Takotsubo syndrome or apical ballooning syndrome or stress-induced transient left ventricular dysfunction or stress-induced cardiomyopathy. There are several names for this. Here there occurs an acute but rapidly reversible LV dysfunction with distinct valve motion abnormalities. It predominantly affects postmenopausal women after a stressful event. There are conflicting reports regarding the long-term prognosis in patients of Takatsubos who survive an acute event, but most of them survive the acute event. So we need to know more about the long-term effects. Next. Dr. Uday Jadhav highlighted on the ADHF 2020 update. He enumerated a scoring system which is essentially based on systolic blood pressure, heart rate, blood urea nitrogen, COPD, and sodium levels. More the score, worse is the prognosis. He highlighted about the loop diuretics, which is a pillar of management in patients with acute heart failure. A continuous infusion should not be tried in patients who have not shown response to a maximum intravenous bolus dose. This is important. One should not start a bolus, an infusion from the beginning. An onset of diuresis typically occurs within 30 minutes with a peak diuresis usually 1 to 2 hours after intravenous diuretic administration. He highlighted the ESC guideline for monitoring and tests in ADHF, creatinine, blood urea nitrogen, and electrolytes to be done every 1 or 2 days during hospitalization, prolactin for coexistent infection. Liver function test is often deranged and it also indicates a poor prognosis. TSH, complete blood count and iron profile should be done. And echocardiography is recommended immediately in hemodynamically unstable AHF patients within 48 hours, when cardiac structure and function are either not known or have been changed or may have changed since the previous studies. One very important thing is about the sodium level. Hypernatremia at discharge is worse than hyponatremia. It was associated with a 6-fold higher 28 days mortality and 3-fold higher 1-year mortality, while hyponatremia is associated with 2-fold mortality at 28 days and 1 year. Next. Surgery for heart failure has been discussed by Dr. T. Sundar. Heart transplantation remains the gold standard for end-stage heart failure. It should be considered in end-stage heart failure patients when other options are exhausted, keeping in mind the risk of immunosuppression. This perhaps gives the best result. If you look at the survival, 1-year survival is 90%, 5 years is 70%, 10-year survival in end-stage heart failure is 50%, and even 20-year survival has been recorded in 20% cases, which is practically unbelievable. Non-transplant surgeries with the STITCH and the STITCHES trial, CABG has come into prominence as CABG has been found to be superior to medical therapy alone. Regarding the ischemic mitral surgery, CABG alone is as good as CABG and mitral surgery because additional surgery doesn't improve survival. And if mitral surgery has to be done, valve replacement is preferable. And surgery for other mechanical complications like repair of ventricular subseptal rupture, surgery for ruptured papillary muscle, etc., has been discussed. Today only about the mechanical circulatory support, it has been discussed just by a previous speaker. Next. Goals at discharge should be discharge with optimal hemodynamics, initiate UDMT as soon as possible, uptitrate therapy as soon as possible, use ARNI preferentially, co-manage comorbidities, vaccinate at discharge, and consider device therapy. One target for post-ADHF patients in patients presenting with acute heart failure already on beta blockers, continue beta blocker treatment unless they have a heart rate below 50 or have advanced heart block or shock. Start or restart beta blockers during hospital stay in people with acute heart failure and HFrEF once their condition has been stabilized. Ensure that person's condition is stable for typically 2 days after starting or restarting beta blockers before discharging him or her from the hospital. Next. Thank you very much.
Thank you, Professor Guha and Professor Das. This was an excellent recap of the entire session. I encourage the delegates to please ask questions. We have a galaxy of moderators and panelists and chairpersons to answer the questions that you might have from the previous day or from today's presentations. May I now request Professor Sandeep Seth to give his opinion about the heart failure clinics. We know that the heart failure population in India is increasing and there are a lot of patients who need specialized care. However, a lot of cardiologists are not yet taking up or not starting heart failure clinics. So what are the barriers there? How we can improve and how can we, what are the things that heart failure clinics can give us better than the usual practice? So Professor Sandeep Seth, to deliberate on that.
Thank you, Vishal. So we've already had excellent sessions on how to manage heart failure, starting from the medical therapy to the surgical therapy. So with all this knowledge, it should be pretty easy to manage heart failure, but in spite of that, something goes wrong. What goes wrong? So do we really need heart failure clinics? We all know how to treat heart failure. We all know the guidelines. Why do you want to waste time and resource on trying to create one new clinic? Treatment has really advanced from the time when we really didn't know how to treat heart failure. We used to bleed patients. We used to make a nick, take out the blood, put blood-sucking leeches to take out what we thought was bad blood. Investigating patients for heart failure is now getting more and more complicated. Taking the history, doing the ECG, X-ray was what we used to start with. Now it's going on to biomarkers, looking at the various biomarkers, looking at various advanced form of echoes, MRIs, imaging, biopsies, genetic testing. So it's getting more and more, and it's going to get even more complicated investigating a patient with heart failure. The treatment has also got more advanced, starting with the discovery of digoxin, then the original diuretics, which were somewhat toxic, and the better diuretics, which became somewhat safer to use. Then the advances in the various forms of medical therapy with the coming of the ACE inhibitors and the beta blockers, more advanced forms of therapy, which we've discussed in the previous sessions, and the use of various surgical forms of therapy like transplants and assist devices, the various forms of pacemakers. Heart failure therapy has really advanced with the mortality coming down dramatically. Various forms of other forms of therapy were also tried with the use of regenerative therapy and gene therapy. And now we're getting down to much more forms of newer forms of drugs like ARNI, ivabradine, and now with dapagliflozin, and also with newer devices like the MitraClips and TAVI. So we are really advancing in the forms of various forms of management of heart failure. And actually today, the patient with heart failure does not have a prognosis as grim as it used to be when it was said that a patient with heart failure fares worse than cancer. Today, probably properly treated, a patient with heart failure can fare sometimes much better than a patient with cancer. So with the advent of ARNI, with the advent of ivabradine, with the advent of dapagliflozin, and also with the concept that many patients with heart failure can actually have reversible forms of heart failure, inflammatory heart failure, or as Rakesh talked about, tachycardia cardiomyopathy. There are various forms of reversible forms of heart failure. So heart failure can actually be treated. But in spite of all that, are we actually treating heart failure correctly? Now, this is all Indian data from Trivandrum, data from Delhi, from Dr. Chopra's data from our own institute from AIIMS. We are actually finding that patients, ultimately, we might be prescribing the patients correctly, but if you look at the endpoint, patients, only about 50% of the patients actually get the correct treatment. So there's a lot of gap from knowing the treatment, prescribing the treatment, to actually being able to implementing and ensuring that the patients actually follow the treatment that you might have advised correctly. Something goes wrong somewhere down the line. Patient might have been given the correct prescription. Some patients don't follow the prescription. Some patients take the prescriptions, the side effects stop them from taking the prescription. Ultimately, only half the patients actually take the prescriptions. The advanced forms of therapy like the assist devices and transplants are available. They're available all parts of India now. But these are expensive therapy, expensive forms of therapy. The government is willing to help them, but for the patient to reach for help from the government is difficult. The devices are pretty complicated devices. Getting them programmed, reaching the correct place to getting the program also complicated. So what's the solution? One possible solution is that you can create an integrated system of supporting these patients using a heart failure clinic. Having trained nurses who can help these patients, having a helpline which is available where the patient can phone a helpline, get in contact with the nurse who is willing to help them. Having a system where they can get in touch with a physiotherapist, they can get in touch with various forms of therapy. And you'll note the doctor is just one part of this management system. There are other components of the system. A single doctor in today's complicated world cannot manage a disease like heart failure alone. And there's a lot of evidence that heart failure clinics actually work beyond just medical therapy. And they are reducing morbidity, mortality, and even hospitalization. And the maximum benefit with this will come in patients, especially who have been recently admitted. And the benefit will actually not come in the short term. The benefit will come only after these patients have been followed for a long time. This is some data from our own hospital. This is our heart failure clinic data for about 400 patients. Patients, when they register in our clinic, this is how they look. About 80% of them are on ACE inhibitors or other vasodilators. About 40 to 50% of them are on beta blockers. Majority of them are on potassium sparing diuretics. At that point, if we start from the mortality data from our ICU, almost 20% of them have had a mortality or readmission rate. Now, by the time we have looked after them for about 3 to 6 months, we are able to push up the vasodilator use, which means either a ACE or ARB or ARNI, or if they have some other problem like renal dysfunction, isoleucine or a nitrate hydrazine combination, we push up the vasodilator use to about 100%. We ensure that there is a beta blocker and or a ivabradine, again, push up to 100%. This is what we call a ABCD algorithm. So A is a vasodilator, B is a beta blocker, C is everything else. So we ensure that CAD gets aspirin, statins, we ensure there's a vaccine. D is a potassium sparing diuretic. So we ensure that at least some level of the appropriate medicines are in the patients. With this, we ensure what we have found is that about 50% remain stable on their symptoms, 37% improve, but 13% obviously continue to worsen. This is the group which ultimately end up in end-stage heart failure management. As of now, we've had about 73 transplants, 7 LVADs in our transplant program. So with that background, now supposing we have to start a heart failure clinic. Now, how do you actually start a heart failure clinic from scratch? Now, are you going to put every patient in a heart failure clinic? It is not possible, nor do you actually need to put every patient in a heart failure clinic. Most of the patients, almost 80% of your patients, you will continue to see in your routine, regular cardiology OPD. Only some of your patients you will shift possibly to a focused area or a heart failure clinic, where you will provide additional management. So patients who have been recently admitted for heart failure, these are more likely to have recurrent events. Patients who have renal dysfunction, diabetes, chronic obstructive airway disease, who persist in having class 3 or 4 symptoms, and who have been having frequent hospitalizations. This is the group of patients who are likely to have almost a 20 to 40% recurrent rate of events, either rehospitalization or mortality. So this is the group of patients where you need to create a separate area or maybe 2 hours per week, which you can call a heart failure or a focus area. So what do you do in a heart failure clinic? You have disease management. That means you manage the heart failure. You provide individualized care for the patient. The nurse or your educator will teach the patient self-care. You optimize the management. That means you push up the vasodilators, you push up the beta blockers. You do some kind of functional assessment of the patient. It can be something as simple as noting down the NYHA class, or as complicated as doing a 3 or a 6-minute walk test, or just asking on each visit, are you the same as before? Are you better or worse? Or how easily can you climb 1 flight of stairs? We use this thing. How easily can you climb 1 flight of stairs? You cannot climb, or you can climb very easily on a scale of 1 to 5. This is very simple to do. Patients who can't even climb 1 flight of stairs are very sick. Patients who can climb 1 or more flights of stairs are doing pretty well. Very simple, and it actually distinguishes patients who are sick from patients who are not so sick. If you want to get a bit more complicated, or you're doing some various studies, you can use a SF12 or SF36 scale. SF12 we use for telephonic, which is now more important, especially now that we are not able to call our patients. So SF12 is easy to do on the telephone. Otherwise, SF36 is slightly more elaborate scale. Drug therapy has to be pushed up. We have a special card. I'll talk about this card. This is a checklist card, very small card, which is given to each patient, which is used for giving education to the patient about their drugs, is used to emphasize medication adherence, and also used for treatment optimization. I'll talk about this card. We also have very, very small single-page checklists for the OPD management and for the ward management. We'll come back to this. If the patient is on a device, we ensure that all patients have indications for device are appropriately advised for that, and the devices get appropriately evaluated and programmed. We get the patients in touch with dietitians. We help them get referred to other departments. We have a yoga therapist with us in the heart failure clinic who teach the patient various forms of yoga which are appropriate for heart failure patients. We ensure that once a patient with heart failure is discharged, patient is seen within 7 days after discharge. And if the patient is very sick, we try to ensure that patient is seen within 3 days after discharge. On a regular basis, we are trying to teach the heart failure nurses and the research fellows who are attending the heart failure clinic, but you have to keep ensuring that there is particular quality which is maintained. The records are being maintained on Google Sheets, which is a very simple way of maintaining the records. Now, these are the tools that we use. We use a card which we call the Hriday card. We have a smartphone app which we call Dharpan. This is available on Google Play Store. We have a prepaid number which we have created. This is just a simple Airtel number. So we haven't asked the hospital for any resource. None of these are resources we have asked from the hospital. These are all resources we have created on, and these are very cheap resources. So very simple to do. We just took a prepaid number which we took from Airtel, and this is the number which we are given to the patient. It works 5 days a week, only from 9 to about 2 o'clock or sometimes 5 o'clock. So the patients can only phone during that time. And there's a Google Sheet-based registry. We have created some rehab videos, which actually the nurses and the physiotherapists have created themselves. And we have certain checklists, which I'll show you. This is a snapshot of the Hriday cards. This is where we put the patient's details, their names and other details, whichever hospital. This is empty space, but any hospital can use this card. So it's not specific to AIIMS. Any hospital can just put this stamp and start using this card. This is the backside of that card, which is used to teach the patient. So weighing yourself daily, drinking less of water, taking less of salt, doing some kind of meditation, not smoking, exercising regularly. So it's all depicted pictorially. It's used to teach the patient about heart failure. When you go inside the card, then you teach the patient about zones, that if you're in the green zone, you're not having worsening symptoms, you're okay. If you're in the red zone, that means your symptoms are worsening, then you have to get to a doctor. Yellow zone is a warning zone, that you're starting to gain weight, you have to be careful. You start taking care of your water intake, but you also be ready to contact your doctor. So we teach the patient self-management. We also teach the patient that in case you have an increase in weight, you start increasing diuretics. And we also teach them that you should keep some antibiotics at home. In case you're not able to contact a doctor, you have persistent cough, you should be willing to take an antibiotic while you're trying to contact a doctor. So we teach as much of self-management as possible to the patient. This is a checklist for the doctor, contains very limited things. So the concept of a checklist is that it should not be very exhaustive, it should be very, very simple. So it contains only a bit about the diagnosis. It contains whether the patient is taking a vasodilator, a beta blocker, and it in what doses. What is the dose currently and what is the target? So that means, have you pushed up the dose? It contains whether the ECG shows atrial fibrillation or a bundle branch block. That means, are we having an indication for anticoagulation? Have we an indication for a device? Have we vaccinated the patient? Is the patient requiring a statin? So it contains very limited things. It doesn't contain too many things. Then we have various forms of booklets for the patients related to various forms like stress management, diet, exercise. So all these things are there. This is a Dharkan app. This is basically an app which connects the patient to one of our heart failure nurses. And we tell the patient that, look, this app is just going to connect you to one of our nurses so that your vitals can reach the nurse, and don't think that this is going to be a substitute for the doctor. This will just send your vitals to us. And if they don't send the vitals, then the nurse will phone the patient and tell them that, look, your vitals have not reached us. So it's just used to send the vitals to the doctor. This is the helpline number. It's simple prepaid number, works from 10 a.m. to 2 p.m. And the patients, if they have any reports, they send the reports to us by WhatsApp. The nurse responds to the phone call. If their queries are simple, that she responds to them. And then if the queries are more complicated, she will always talk to the doctor. For major decisions in terms of treatment changes, she will always talk to the doctor and then get back to the patient and make the treatment change. She will not independently make any treatment changes. This is a very simple Google sheet. So it just contains the patient's details, name, ID, phone number, diagnosis, and contain the first prescription, what was the initial prescription, and then the last prescription. So you know the first thing and whatever is the last thing. So these are some of our exercise videos. So, and these are very simple exercise videos. As you'll note, the entire exercise is done sitting on a chair. The patient doesn't have to get up. The last step is standing up. So even the sickest patients can do these videos. So just arm lifting, leg lifting, knee bending. These are very simple exercises. So even the sickest patients are told that, look, these are very simple exercises. Anyone can do these exercises. So our heart failure nurses are trained in managing all kinds of patients, whether it's a transplant patient, whether it's an assist device patients. They are trained in looking after patients, programming the devices. They go to the wards, look at the various patients. They apply the heart failure checklist, which I'll show you. And they are now trained in also training other nurses in heart failure management. This is part of our yoga rehab program. So we have a separate area where patients are trained in yoga. Again, the yoga is restricted to the kind of yoga which is possible in the kind of yoga which is possible in patients with heart failure. So there are no breath holding exercises, it's all gentle exercises. This is the ward checklist. It's actually a one-page checklist starting from how to use diuretics, inotropes, ACE inhibitors, beta blockers. So it's all a yes and no checklist, and we have to ensure that all the answers ultimately become yes by the time the patient is discharged. So starting from that, so now supposing you have to actually start a heart failure clinic, how would you actually go about starting a heart failure clinic? It's not actually so complicated. You would actually need to first perhaps decide that, okay, you're going to start in a very small way. Start with just maybe 1 hour per week, which you say that this is my heart failure clinic time. So you don't say that I want a separate room, I want a separate staff. Then take any help. When we started, we didn't have any help. I actually had 2 interns who said, okay, we want to do some research. I said, okay, you do want to do some research, we'll start with doing some research. And we created a first set of protocols, and they actually wrote a very good paper out of that. So you can start with anyone. It can be a student, MSc nurse, a PhD, someone wants to do a PhD. It can be even a hospital attendant or paramedic, anyone who's willing to help becoming a counselor and data collector. So any one person to get you started. Then you can use the Hriday card, which is available with us. You can have it reprinted or we can print it for you. So that simple card becomes the first tool as an education tool for medication adherence and data collection. You can just enter the data in it, take a photo of it, and that contains all the data you need for and create a helpline number. So just a simple Airtel prepaid number costs 34 rupees per month to run an Airtel prepaid number. So it's actually very cheap. And you make it run 5 days a week, just 3 hours a day. Patients get very well trained that they know that they can only phone for 3 hours, 5 days a week. They will not trouble you, and you are connected through the nurse. Now, this is a model which I actually created this slide yesterday. This is something which I thought maybe Vishal and Bhagirath and all would have a look at, because we have realized that this works the heart failure clinic concept might work very well in a government setup, because there all the other cardiologists are sending patients if you create a heart failure clinic. In the private setup, probably it doesn't work out. Vishal has worked very hard. He's created an excellent heart failure clinic. The problem he possibly faces is that everyone does not send patients to the heart failure clinic. That seems to be true in a number of other heart failure clinics, which I've seen in other private hospitals also. Excellent heart failure clinics, but everyone possibly for various reasons is not willing to send patients to them. I don't know whether this kind of model which I'm suggesting is going to work, but I'll just go through this model. This is something for discussion. I don't know whether this is going to work. What I'm suggesting is that maybe if you have a walk-in heart failure daily service or a weekly clinic or a weekly service, where patients can be referred by cardiologists, surgeons, or anyone who's managing heart failure. And you start with, again, as I suggested, sick patients who have had heart failure in the first 3 months. And this clinic or service is actually run by case managers who are either senior nurses or dietitians, along with the heart failure nurse, part-time physiotherapist, dietitian, and device programmers. And this service is actually supervised by 2-3 senior cardiologists. So they are supervising this service, but the patient actually remains under the care of the referring physician. The supervising cardiologist will create checklist protocols and they will maintain the standards. And all the participating physicians meet periodically to view anonymized data. And what the service provides is that they will basically, all this group of senior nurses, dietitians, heart failure nurses, they can also be a junior physician in this team, who they will provide education on medication adherence, dose adjustments, vaccination, diet, physiotherapy, device programming. They can create a telephonic helpline, weekly, monthly phone calls to the patients to ensure compliance, and they can provide all this data back to the primary physician. And they can also make a phone call to the primary physician that, for instance, if the patient is on Ramipral 2.5, they are trained to check what is the blood urea, serum creatinine, blood pressure, potassium. And if everything is normal, they can inform the physician that possibly the drug can be increased, but they are not authorized to make any changes. They can only make a suggestion. So this is a possible model which I've suggested, but since I'm not in the private sector, I don't know whether this kind of model will actually work. Now, what is our experience? We run a heart failure clinic once a week. It's on a Thursday from 2 to 6 p.m. We see patients with end-stage heart failure with various forms of cardiomyopathy, unexplained heart failure, which has been referred to other hospitals, or patients referred for heart transplant and assist devices. And as I've said, we optimize medication to improve outcomes and all the things that we do. Also doing various forms of genetic testing, MRI, PET, biopsies, also linked to various other research institutions like the Institute of Genomics, Delhi University, and various research protocols are being done. And these are just glimpses of some of the things in the heart failure clinic. Now, this is what we do. If moment the patient comes, we put a stamp on the patient's OPD card. This is the ABCD stamp. So A is the vasodilator. So we group it as the, for instance, Ramipral will put under A, beta blockers and ivabradine. So that we put in B. C is for everything else, and D will be the diuretics. So this way you organize the drugs in the ABCD format. This is what we call our ABCD format. For patients who are not very compliant, we have similarly ABCD Ziploc bags. We put their drug, we ask them to bring their drugs, we put the drugs in similar bags. Obviously the C Ziploc is much bigger, and we keep teaching them till they become a bit more compliant. These are some of the checklists. I don't have much time, but these are some of the checklists that we use for in-house patients for transplant, LVAD, post-transplant man. So there are very, very small, these are all single page or half page checklists for each of our components. It makes it easier for the nurses to follow. These are collabs. This is just a glimpse of actually what the some of the patients actually with them, what the heart failure team looks like. This is a result of a lot of research work. This was the first paper which came out. Half of them are actually the interns who actually helped me start. In 2007, we brought our first paper from the heart failure clinic. This is the first protocol that we created then. So some of the work that we've done is just a glimpse of a heart failure clinic. Thank you. And this is the site from which most of our work is available. So on this website, you can just download most of our work and some of our checklists. Thank you. If anyone has questions,
that was a great talk. And do we take questions right now, or we can, though the talks are very different, but we've not had very many questions thus far. Maybe people are taking their time to,
Sandeep, I think we should discuss a few things.
Okay, so there is one question which is already there, and Dr. Kumar Pal has asked, Dr. Sandeep Seth, you partly answered that. Maybe you'd like to reiterate on the same. He has asked, how can we start or set up a heart failure clinic, and what may be the criteria for OPD basis? That is the exact verbatim of the question. And I know partly you've answered that, but how does a person maybe in the periphery or a regular hospital start this? You did highlight the problems between government versus private, but for a routine hospital, say a multi-speciality hospital or a routine hospital, regular hospital, how does one start really?
So may I rephrase the question? The question probably the person wants to ask as to, out of my 100 or 200 patients which I see in general cardiology OPD, which patient should be seen in the heart failure clinic, which heart failure patient should be seen in the heart failure clinic. So probably the high risk pointers or the, as you have said, so probably those things I would think that you would like to.
Yeah, okay. He did tell those.
Okay. So supposing you are seeing you're having an OPD 5 days a week, you will be seeing maybe 20% of the patients will be heart failure every day. So there is no point in seeing all those patients in a heart failure clinic. So what probably you would do is that you decide, for instance, that Saturday, 2 hours a day is your heart failure clinic. So Saturday, you call for 2 hours a dietitian, a physiotherapist, that for 2 hours, okay, a dietitian, a physiotherapist will come, for instance, 9 to 11 or 11 to 1, a dietitian, a physiotherapist can come to a designated area, which can be your clinic only. So for those 2 hours, a dietitian and a physiotherapist will come. Every day you keep seeing a patient. Even that day you see a routine OPD. During the entire week, you keep isolating the patients who are more sick, very sick. For instance, they have been recently admitted in the past 3 months or 6 months, or they have renal failure, or they have diabetes. I mean, they have high risk markers, or their blood pressure is low, they can't tolerate beta blockers, they can't tolerate ACE inhibitor. That means you know that these are sick patients. Call them on Saturday 11 to 1, for instance. So while these patients are sitting with each other, they will talk to each other, they'll share their experiences. Then the dietitian will talk to them as a group, the physiotherapist will talk to them as a group, and you also create a helpline number, a simple prepaid helpline number, which turn by turn, your receptionist or your secretary can hold that phone for just 2 hours a day. So that's a very simple way by which this thing can be started. So don't do anything else, just start this much, by which the counseling will start. And whoever sees these patients just notes down the patient's name and phone number and takes a snap of their OPD card. Nothing else. Don't do anything else. Once this thing starts, you'll automatically get things organized. This is a very simple way to start your heart failure service. Don't ask for any resources for anyone. You can start this and gradually people will start copying you.
Sandeep, let me ask you two things that come to my mind from this. So typically, as you said, we need not take up stable patients. There would be patients who would eventually become stable once they've been enrolled in the heart failure clinic. So do you have a move out also of the heart failure clinic, or once you've enrolled them, they stay right there?
They stay right there. No one is willing to move out to the busy routine OPD. They think they would prefer to stay. No one is willing to move out.
But then the numbers in a hospital like yours or mine would keep burgeoning, you know. So you'll run out of your time for heart failure clinic managing the
We
number of...
we reduce the frequency of their visits.
Right. And
that's the only way to manage.
The second thing is, you know, though we've talked about this, I'm needing your comment, and I'm also reiterating that, you know, when you have a group of peers, similar people, group of people with heart failure, and a nurse or an educationist talks to a group of people with similar problem, perhaps the identification with the other people is better. You also tend to understand that I'm not alone in this. There are other people like me. So how much does this, in your experience, have an effect on betterment of the patients?
Maybe he did not listen to your question, Dr. Sandeep. But yes,
I had lost the connection. I just got the connection back.
All right. So yes, I can answer that, because
what
that's
I
a very...
was saying was that
I think I'm losing the connection again and again. Just
Vishal, maybe you can briefly answer that. You know the question.
Yeah, Vishal, maybe you can answer this.
Yes, definitely. That's a very important point. And, you know, we have worked hard to create even support groups also based on the similar principle that, you know, the patient sees other patients, he learns from other experiences. So a lot of our transplant patients they are in a single group, and they keep talking to each other that this drug is not available, this drug is available, what is the substitute for this medicine? So, and that helps a lot. And, you know, if a lot of heart failure patients come in one group at one point of time, they are able to see that, you know, there's not something which... A lot of these patients are depressed and they think that they have lost hope. But yes, once they see people like them, they definitely feel better, and they feel a ray of hope there.
Right.
So, Dr. Sandeep, may I, you know, you raised a very valid point as to, you know, the private institutions are not able to go with the heart failure clinic program because, you know, nobody wants to lose their patients. So in the sense, and Dr. Vijay Chopra is here, and he is running a very successful heart failure program earlier at Medanta and now at Max Hospital. I'm running it at Fortis Escorts. My experience and our experience here is that if you give good quality service, if you as you have rightly mentioned, that nobody wants to move out of the program once they enter the program, because they feel that you are giving good care to them. And once you start giving the advanced treatments like heart transplant and LVADs, then probably your colleagues will also start referring those patients to you, because now the patients are becoming aware that I'm suffering from end-stage heart failure, and then why are you not offering those treatments to me when they are available everywhere? So we have come a long way from those area when my colleagues used to ask me, why should I refer my patient to you? Because I can also adjust their Lasix doses. I can also give them these guideline-directed medical treatment to now, these advanced treatments which we are more versed with, or we are, we are in a better position to suggest to these patients. So I get very frequent referrals from my colleagues. Yes, I agree with you that we have to give the ownership of the patient to the original physician. That's, in private practice, probably that's the most important rule of thumb, that, don't try to grab a patient. Patient should go back to the original physician after you have given the correct advice. And you should encourage that patient sees the the primary physician or the referring physician at each visit that he sees you, maybe just for the sake of, just showing face that, okay, I have seen Vishal and I'm okay. And they are very happy to see the patient that they are doing well. Dr. Chopra, your opinion on that?
I think you did right. You mentioned all the points which need to be mentioned. So ownership has to be with the primary cardiologist, because that is one thing which holds them back. And even that confidence will come very, very gradually. It doesn't come straight away. Just because you tell them that no patient is going to go back to you, it doesn't come. So that way, what Sandeep Sandeep said is in a different situation than what you and I are. So I think maybe we can get on with the second talk, because time is running out.
Yeah. So for the second talk, it's my pleasure to invite my good friend Dr. Tiny Nair. He's going to tell one of the reasons that we are in this platform and not live and together in a meeting or a conference, and we are virtual, is because of COVID-19. And so heart failure in COVID-19 era is a very relevant topic. And I'd request Dr. Tiny Nair to please deliver his talk on this very important topic.
Thank you. Thank you. Give me a moment by the time I share the screen. Yeah, so the topic is heart failure management in the COVID era. What do we do about it? I think as has been mentioned by the chairpersons and the moderators, that we are passing through a very difficult time, right? Something that we had never ever imagined all these years, like people standing in long queues, as you can see there in the picture, for supplies, right? And this is not a third world country, right? This is from the US. So people are standing in long queues, and if you follow that queue, you can see that not just that it turns around the corner, but people are sitting on chairs, which means they had been waiting since late night for the sun to come up so that they get their supplies. But the point is, it's not food. Well, they're waiting to buy guns. So the whole point is that COVID-19 has changed the entire spectrum of the way we look at life. And that is also relevant when we look at the science of managing heart failure, which is really a big, big challenge. Now, the Trivandrum Heart Failure Registry, which was organized, led, entirely conceptualized and led and to the finish by Professor Hari Krishnan, a good friend, and we just played a small part in it. But the publication of Trivandrum Heart Failure Registry taught us a lot of lessons, right? The in-hospital mortality in India in Trivandrum was 10% in heart failure, 1-year mortality of 30%, 3-year mortality of 45%. But that is not the point. The point which is relevant in the background of COVID-19 is this. When we looked into the data at Trivandrum Heart Failure Registry about the guideline-mandated therapy, guideline-directed medical therapy for heart failure in patients, let's say the worst patients, those with left ventricular systolic dysfunction, right? In those patients, we find that if you look at the graph, the red in guideline-based therapy, the blue in those who did not receive guideline-based therapy. And look at that. Those who did not receive guideline-directed medical therapy had a far worse outcome. Their event rates were more than double, almost triple, right? So very bad. And not just that, we found that guideline-directed medical therapy at discharge from the large hospitals in Trivandrum, which were participating, had received only 24% of the patients received GDMT. So patients of left ventricular systolic dysfunction, leaving good hospitals like our own, had only 25% receiving GDMT and 76% didn't. And those 76% had an extremely bad outcome, right? So with that background, we should also realize one slide which we had seen a little while ago, This is from Muthaya Vadaganathan and Milton Packer's group from Baylor College from Dallas, Texas. This is not a trial, but this is an estimation of the lifetime benefits of comprehensive disease-modifying pharmacological elements. So what the authors in this Lancet reviews did was they took out ARNI, they took out MRA, and SGLT inhibitors. So the new 3 disease-modifying agents of heart failure, which actually reduce mortality, right, and put them on graph. So on top of standard therapy, okay, beta blockade, you have your ARNI, your SGLT inhibitor, and MRA. And that gave us a 60% reduction of cardiovascular death and hospital admission, 50% reduction of cardiac death, and all-cause mortality reduced by 50% roughly, right? So guideline-directed medical therapy is important. Very few people get it. And if we move on to the present standard of therapies of MRA, ARNI, and SGLT inhibitors, we can probably reduce the disease burden massively. But the first challenge is, how do we provide GDMT for our heart failure patient in COVID times? How do we do that? And I think the answer should be that we should, in this point of time, try to start GDMT pre-discharge as far as possible. Because once the patient goes during the COVID times, we don't know how frequently we are going to see him, whether heart failure clinic or no clinic. These times are difficult. He may not come for telemedicine, he may not come at all and continue to take medication. So if possible, can we start GDMT pre-discharge? And that answer partly came, for example, ARNI, that answer came from transition trial. We all know that 19 countries, 156 sites. So basically 1,100 patients were put on either pre-discharge ARNI or post-discharge ARNI. Basically trying to see, the primary endpoint was not event, but primary endpoint transition was trying to see that can they tolerate or are we able to achieve target dose of valsartan sacubitril, right? Are we able to achieve target dose? And that was 200 milligrams BID at week 10, right? So the comparison was the dark green was pre-discharge and the light green was post-discharge. And we found that if we looked into the primary endpoint of reaching target dose of 200 milligrams BID of sacubitril valsartan, we see there's no difference, right? The p-values are 0.9 and 0.09. So we can, certainly we understood that we can hike up our dosage and patients would tolerate ARNI if we start pre-discharge. And as you see on the rightmost bar, the adverse effects were really permanent discontinuation because the adverse effects were really negligible. And again, comparable whether we started early or we started late. So we have an opportunity of starting the drug early, right? So the question comes in, for example, in India, do we start for everyone early? So there's a very interesting sub-study of transition that came in, which looked into de novo acute heart failures, right? So they differentiated patients of those who came de novo heart failure versus those who had prior heart failure. There were about 286, 29% patients in transition sub-study, which had de novo heart failure. Now, de novo heart failure, interestingly, very significantly differed from those who had prior heart failure, those 705 patients. They were younger, 62 years compared to 68 in the prior heart failure group. They had less hypertension, right? They're less diabetic and lesser number of AFib. So that significantly lesser incidence of hypertension, diabetes, AFib. They were younger. But the interesting point is they had a worse LVEF. So worse LVEF, younger age, lesser hypertension, lesser diabetes, and lesser of AFib. Now, when we looked at the data between, so this is not between early and late, this is between de novo in dark blue and light blue is prior heart failure. And we found, yes, with the same primary endpoint, now there was a difference, which means far more people with de novo heart failure tolerated valsartan sacubitril ARNI, right? Far more people tolerated pre-discharge compared to those who had prior heart failure. So that is a group, probably they would tolerate it better. Now, interestingly, when they looked into the first heart failure rehospitalization of these group of patients of ADHF de novo who had sacubital valsartan, so in the y-axis you have cumulative probability of heart failure rehospitalization, and on the x-axis you have the day, right? You see at 26 weeks, there was a significant difference between the two groups. Okay, so telling us between the de novo and the prior heart failure group, telling us that yes, in this group of de novo heart failure, probably you derive more benefit in terms of rehospitalization in the long run if you start them pre-discharge. Not just that, look at the same data set, look at rehospitalization or cardiovascular death, combination, similar kind of benefit. So probably a subset of patients who come with a de novo heart failure for the first time, who are comparatively younger, lesser hypertensive, lesser diabetic, lesser AFib, but a worse ejection fraction, they are likely to tolerate pre-discharge in hospital ARNI better. And probably we should try to put them, especially in these times of COVID, where his chance of coming back for us to up-titrate dosage are likely to be less. NT-proBNP in the group who had de novo heart failure also reduced far better compared to those who had prior heart failure. Obviously, a damaged heart versus a de novo, people who actually responded better, understandable. Now, so the first challenge of can we start GDMT pre-discharge during this COVID time? The answer is yes, right. So from that point, we take up this challenge 2. Challenge 2 is the real challenge. Heart failure follow-up and therapy tailoring during COVID times, right? The patient is unable to come. Obviously, there's question of social distancing. Now we are careful, the patient is careful, we are careful, we don't want to see him. So we are more like in a virtual platform. So in that virtual network, where I'm unable to see my patient physically, can we tailor an up-titrate, which is important, up-titrate heart failure medication dosage? Now, we don't have there's a fantastic checklist that, as you saw from AIIMS, but then, ours all are small hospitals where we have our own kind of band-aid solutions. Like what we do is we just follow that whenever we do a tele consultation for a heart failure patient, we make sure that the patient and spouse both are there. Because there are many things that the patient may not tell us, but his or her partner might be telling that this is the problem. And first thing we ask, is there a change of threshold of effort tolerance? Because we have seen that if we have a lot of questions, that 10 minutes time what we spend in teleconsultation will be wasted. So is there a change of threshold of your effort tolerance? Yes or no? Point number 2, do you have orthopnea or lack of sleep? The wife might say, yes, now he's waking up 3 times at night and sits up for some time and goes back to sleep, which means his symptoms are worsening. Third, do you have leg swelling? Do you have leg swelling, edema? And fourth is, do you have paroxysms of palpitation, which means I'm thinking in the line of AFib. So change of threshold of effort tolerance, new orthopnea, edema, and paroxysmal palpitation are the basic 4 things that we ask one by one in the teleconsultation that we do. And we ask them in Kerala, generally we have a population, a clientele who are not rich, but they are knowledgeable. Their medical knowledge is good. So we ask them that buy 4 things. 1, get a digital weighing scale and you use it only for you, so that every time you check on that and let us know. Number 2, go to one of those sites, Amazon or Flipkart, and buy blood pressure apparatus, and we clearly tell them which of them to buy. A series of them, you can choose anyone, but one of those AHS is certified or EC compliant. Third, if possible, it's not very expensive, buy a good, obviously non-Chinese, buy a good pulse oximeter, right? A couple of good brands are available, and that's not very expensive. And today we have labs, local labs. We don't tell them that you come to the hospital and check it out, because obviously your lab, my lab in hospital will be far more sensitive and reliable. But we tell them locally, if possible, just check 2 things, serum creatinine and serum potassium, so that I can know the GFR and the potassium. So if I know whether he's losing or gaining weight, how is his systolic blood pressure, how is his SpO2 and heart rate by the pulse oximeter, his serum creatinine and serum potassium, I can confidently alter his medication dosage? So we very clearly ask those 4 questions and ask them to use 1, 2, 3, 4, these 4 tools, so that we can make an intelligent decision making in up-titrating dosage of heart failure medications. Which one do we go up first or second is again a personal choice, depending on whether it's getting volume overloaded or not. But we should remember that still, beta blockers are probably the one that had produced maximum mortality reduction compared to other drugs. And you can choose your way, the way you move. That is entirely your choice. I think from managing heart failure in the COVID times when we are discussing about heart failure, the challenge 3 is COVID-19 directly affecting the heart and causing heart failure, right? And we know a lot about COVID now, and there are even more things that we don't know. We know that COVID affects lungs and mostly creates hypoxia, and that is responsible for most of the cardiac problems. But we also know that it can create cytokine storm, it can create DIC, it can create direct cardiotoxicity. And we also know what all can happen. We are all cardiologists. We know that there may be acute coronary syndromes, arrhythmias, myocarditis, thromboembolic phenomena, heart failure. We are not going into that. But interestingly, 2 subsets stand out. One is when we get a call that there's an elevated troponin. So a lot of elevated NT-proBNP. Elevated troponin and NT-proBNP in the background of a normal EKG and a normal echo is not uncommon. But very clearly, they tell us that there's a worse prognosis. So elevated NT-proBNP and an elevated troponin in the background of a normal echo and a normal EKG, apparently the heart is not involved, carry a bad prognosis. And of course, we know that the entire stress of ventilation and whatnot can give rise to Takotsubo, but we are not going to that. I think we should spend 1 minute on something, and that is fulminant myocarditis. Initial phases itself, we were distinctly told that myocarditis is distinctly uncommon in COVID-19. But today we know there are anecdotal cases where we find an echo like that. The angiogram is normal, there's no ischemia, but basically suddenly there's reduction of LV function, the cavity looks large, but as time passes, the echocardiogram changes onto where there's myocardial edema, so that the myocardium looks thickened by the echocardiogram, the cavity tends to become smaller, and again, we can see that there is LV dysfunction, but over time, the edema goes away and the patient improves, the typical of fulminant myocarditis pattern. So fulminant myocarditis may be rare, but they can occur and give rise to cardiac failure in a patient of COVID. But there is something extremely interesting that has come just yesterday. In case you have missed it out, it is the outcome of cardiovascular MR features, magnetic resonance features in COVID-19. What they did was, this is 100 patients who had COVID-19 and admitted and got discharged, right? And these patients did not have any obvious cardiovascular problem. So COVID-19, 100 patients got admitted, no problems at all, no cardiac problems, got discharged. And they were compared with 50 normal patients who did not have COVID. So 100 patients, COVID recovered, no clinical CVD. They found that in routine cardiac magnetic resonance, there are changes in the myocardium in 70% of the patients. 70% of patients had some kind of changes in the myocardium. Very interesting data. Now, if you do a myocardial biopsy, which was done in a couple of cases, they have shown that there is tendency for myocyte edema. You can see there is a lot of edema between myocytes, both the left and the right stained slides. And there are lymphocyte-associated antigen positive. You can see those dots there, or CD450 RO positive, which again is stained there. So there is some kind of lymphocyte infiltration with myocyte edema. But what is interesting is this: 70% of the patients showed there's a change in T1 and native T2. The left is T1 and the right is native T2. Despite that, they did not have a cardiovascular affliction clinically during their COVID stay. And not just that, you do a late gadolinium enhancement. You see on the right panel, you clearly see that a small pericardial effusion is there. And the left panel, you see there is something like an epicardial enhancement of late gadolinium. So, whatever, there is a myocyte change in COVID in a large number of patients who it seems had no apparent cardiovascular disease. And that is a learning point. That's a real learning point. But hold on, the even more interesting thing is here. When in this study, they looked into in the x-axis, the time since diagnosis of COVID, and in the y-axis, native T1 variations, right, in the cardiac MR. You see there is a huge scatter. There's a huge scatter. And the relation is what? Nothing. Statistically insignificant. It's a flat line. So the R value is what? 0.08. P-value is 0.43. So the time of diagnosis and this T1 abnormality by cardiac MR did not match. They looked into the time of diagnosis in the x-axis and the high sensitive troponin values. No, nothing. There's no match at all. Again, flat line. Which means the cardiac affliction by MR is not matched by duration of disease, not matched by clinical symptoms, not matched by clinical findings or a biomarker. But they are distinct abnormalities in 70 out of 100 patients. Now the question comes in that, does it mean that these patients have a 70% chance of transition to dilated cardiomyopathy later, like the way of natural history of myocarditis? We just don't know. Maybe we have to wait and see. Will they go in for in the long run into a low-key LV dysfunction? Or does it mean that since we have seen an MR abnormality, we should put them on anti-failure drugs? They are in class A. Should we put them on ARNI, DAPA, ACE, ARB, or even an MR? We just don't know, or at least an MR to prevent maybe a myocardial fibrosis. The answer is we don't know. I think the challenge 4 and the last challenge that I would discuss is, obviously everyone is aware, they missed ACS presenting with heart failure. I mean, there's a lot of debate as to where has this ACS gone? Are they missing? Is it because of less pollution, staying at home, better diet? I personally don't believe it. I, in Kerala, think that they are not presenting. Because, generally in a population where we practice, where there's a lot of people's knowledge about medicine, slight dyspepsia, slight throat pain, little back pain not going away, people would come to the hospital to just rule out, is there a problem? And they would turn out to have maybe an ST elevation MI, non-ST elevation MI, get an angiogram done, and very clearly risk delineated. These patients are not coming at all because they know that if I go to the hospital, I might not get an attention. Obviously, this is the problem. This is Delhi. And you can see that this is a Google picture showing you can't really move out. Kerala is in persistent lockdown. The city where I sit is in persistent triple lockdown for the last 4 weeks, right? We can't travel. Okay, and the patient knows that if they go to the ER, this is how they're going to be received, as a potential COVID. So everybody would want, unless there's a significant problem, I won't go. A little jaw pain, forget about it. A little dyspepsia, okay, that can wait. So I think that we are missing it. And it is true because today, in the last 1 month, we are seeing huge number of undetected, fully evolved MIs coming in with cardiac failure. In fact, not just the people at large, there's a lot of medical opinion coming in. For example, there's a very interesting heading, unconnected to our topic, but I put it because this came in European Heart Journal. Self-treatment for acute coronary syndrome. Why not? So one argument is with the potent antiplatelets coming in and with the good antithrombotics, why can't you treat yourself at home for acute coronary syndrome? We really don't. Again, this is something that came in European Heart Journal, like that very much, the black swan. We know that the black swan doesn't exist, right? It is only in our brain. There's no black swan. But once in a while, black swan can come. And this is one such state. So we are in the era of COVID-19, something that we never expected. 10 years back, somebody asked us that the virus is killing a lot of people, millions of people worldwide. Is it possible? No, it can happen only in a horror movie. Like it's just out of the movie, but it has happened. The black swan is here. So I think it's in time when we should tackle the heart failure management. And my major take-home points would be these. Number 1, pre-discharge initiation of GDMT, guideline-directed medical therapy, is extremely important at this point of time in COVID, because if we can do it, and if we can make sure that without coming to the hospital, he continues that, his long-term outcome is likely to be better, which we have clearly seen in the Trivandrum heart failure registry. Point number one. Point number two, simple tools. You make your tool. You have seen a fantastic tool presented to you by AIIMS, but devise your tool. If you are unable to create a heart failure clinic, have a simple tool. Today, about 2 months back, we were saying, what is tele consultation? You won't go for that. Today, the number of teleconsultations we are doing in the hospital is huge, right? So simple tools for online management of heart failure. You have seen our tool, 4 basic questions and 4 simple tools, a weighing scale, a pulse oximeter, and blood pressure automated apparatus with 2 distinct biochemical readings. COVID effect on the heart, unknown long-term effects. We really don't know. So I think we should not discuss and get confused, but we have to wait. It might be that in the long run, COVID-19, the virus itself might create a low-grade, a huge number of LV dysfunctions. We really don't know. Missed ACS, presenting as heart failure is a challenge, but this is probably not a forum where we can address that. We should probably more aggressively address as to how we can tackle the ACS, whether they can be more thrombolyzed given lytic therapy or whatever can be done, and how we can afford not to lose a patient because of COVID, but ACS, telling patients that ACS is far more important than the risk of COVID. So with that, stay home, stay safe, and thank you for your time and attention. And I will unshare the screen and go back to the moderated discussion session.
Thank you, Dr. Tiny. Fantastic talk as usual. And before we go further, I'll invite my co-moderator, Dr. P.C. Negi. Please, any questions or comments or remarks at this time, please, before we go to the questions in the chat box.
Dr. Sandeep Bansal, I do agree. Very excellent talk by Dr. Tiny Nair regarding the challenges of heart failure in COVID era. I would just like to ask Dr. Tiny, because COVID is a disease state where there's a hypercoagulation. You have a DIC, increased tendency of clot formation, and this could be one of the reasons for maybe that in COVID may increase the risk of ACS also. So we use a standard treatment for reperfusion, for example, the thrombolytic therapy and PCI. But any reports regarding the efficacy and maybe the tolerability of the thrombolytic therapy in treating ACS in patients with COVID positive?
Yeah, thank you for the question. I think the thrombolytic therapy was prescribed for COVID, not with an idea when we started talking about lytic therapy more, was not with an idea that there is more of coagulopathy, but started with an idea that we need not expose our cath lab staff to the exposure of COVID, and that is how it started. Really, I don't know the answer, and I really don't have an answer whether in the background of COVID, if we are suspecting that it's in COVID induced. But I think patients who come extremely sick with COVID in our medical ICU and those who develop an ACS later is a totally distinct, different ball game compared to the standard garden variety of ACS. He develops a chest pain in the night and comes here where we just test COVID. He might turn out to be positive. So I think they're totally different. If you are having somebody with an in the medical ICU with COVID and he develops an ST elevation, like we know that any viral infection can precipitate an ACS, that's a different from the garden variety that comes. But I'm not aware of any study which says that lytic therapy is better than primary PCI. Here in Trivandrum, I'm in a private hospital, but again, Professor Harikrishna is there. His experience might be different. We still have primary PCIs coming in, and we do the primary PCI in patients who really need it with full PPE kit, and then put them in an observation area till we get the CBNAT. And once they're negative, then we put them back into the ICU. Very little number of lytic therapy in our hospital.
Yeah, we also do the same.
Yeah, the second part, which I think Dr. Tiny has really brought to our attention, that large percentage of patients clinically asymptomatic with MRI abnormality. That's interesting. I think subsets of COVID patients with subclinical maybe myocardial involvement, although they do not have any markers of tissue injury and evidence, the echocardiographic or clinical evidence of heart failure. I think that the follow-up of these patients would be interesting to see whether they turn up some of the patients into dilated cardiomyopathy later on. What is the mechanisms, how the marked edema in the myocardium without any functional abnormalities, systolic or diastolic, is something very interesting to see.
Yeah, true. Must be some kind of myocarditis. In fact, all of us must be, we get so many phone calls from physicians asking that, can we start on Pradaxa? Can we start on Xarelto? We say that we just don't know, right? Electively, everybody starts them, or the sick patients of COVID on low molecular weight heparin, presuming that there's a coagulation going on, sick COVID patients. But do we have a data on NOACs? I think we don't.
Thank you, Dr. Sandeep Seth. We have a question for you in the chat box. Dr. Sandeep, are you there?
Yeah, I'm there.
Yes. So we have a question for you in the chat box from Dr. Ramachandra, and he says, would a longitudinal funded project meet the expectation of your dream? I fully agree that in a government hospital, for financial reasons, there should be a separate fund for a heart failure program in government hospitals. Do you agree or disagree with that?
No, as of now, we have all the support that we need for the heart failure clinic. So we have 4 heart failure nurses. We have a physiotherapist who's a yoga physiotherapist. We have, as per requirement, device programmers, dietitians, everything. So as of now, we have all the support staff that we need, and I have 2 or 3 research fellows. So I have actually fully funded heart failure clinic. Probably what I was trying to say is that you should not see that you have to have a fully funded heart failure clinic. See, when I started, I had nothing. So what I did was that I started with nothing, showed that this is what I can achieve with nothing. And then with that, then I started asking. I asked for 1 heart failure nurse. I asked for 1, I got 4. I was told that what can you do with 1? You need at least 2 or 3 or 4.
Right.
That is what the chief of cardiac surgery gave me. See, when I started losing heart transplant patients unexplained, I said, look, I can't do things alone. I need at least a few nurses to help me. Because nurses will not go away, residents will go away if I train them. So he gave me 4 nurses. So that nurses number kept going up and down. At the moment, it's stable at 4. So then I started building up the resources. But initially I started with nothing. So it's not that you need funds otherwise, but you just start by proving that you can do something. That can happen with anything. That's what I said, that you start with a minimum resource and then build it up. And that's the same thing. I'm sure that's how Vishal also must have started. He would have started by proving himself. That's how now he's built up an extensive service. Dr. V.K. Chopra would have done the same. That you have to prove your credentials, and then things automatically start happening.
Right.
So may I just, Dr.
Yes.
Sandeep, may I say something? So we must understand that the heart failure program as such is a very cost-intensive program. But what Dr. Sandeep has suggested, the heart failure clinic model, that's not a very cost-intensive program. World over, the heart failure clinics are run by the nurses. They are physician-directed and run by the nurses. So they have nurse practitioners, and they have all the rights to prescribe medications and change prescriptions also. We have different scenario there in the West. But here in India also, the same thing can be developed. We can give these nurses a bit more confidence. We can teach them, and that's what my heart failure nurses do. They they are in touch with the patient. They continue to talk to the patient. They have the full rapport of the patient, and they would be answering their calls in the middle of night. And they'll be, they're very happy that way, that they are doing something worthwhile, more than just, charting their blood pressure and pulses. So these are actually run by the nurses. We just direct those nurses if the situation escalates.
Right. The one interesting question that comes to my mind is regarding the assessment of quality of life. We realize post DAPA, suddenly the quality of life factor has become extremely important, and as cardiologists, we have always thought that we should prolong the life, but DAPA heart failure also said, no, you not only do that, you also improve the quality of life. Now, there are certain mandated, well-established and validated tested scores like the KCCQ. In fact, there is there is a recent Medscape video lesson on which is dedicated to the usefulness and simplicity of KCCQ. There are other scores also. Tiny showed that they've developed their own score. So this actually Hari Krishna could take on behalf of CSI, or Dr. Chopra could also chip in. What should we do to have a uniformity? And KCCQ or other scores, if you want to include in your study program, it costs you $5,000. Particularly for some study program or some project, it is costly. So where do we find the middle pathway? Any one of you guys could take it. How do we have a score for our country? Either we adapt the KCCQ, we say that give us a one-time waiver. Hari Krishna wants to answer that. Go on, Hari.
Yeah, we know there are a lot of quality of life questionnaires. What we are doing as part of the ICMR Center of Excellence project, we are developing an Indian-specific heart failure questionnaire. So it will be, we are collecting all the, initially we run the existing questionnaires in the population, and then we have now reached the stage where we have developed our own few series of questions. We will run and select the best few numbers which are feasible to execute in a population, and whether it is relevant to our Indian culture and our way of living, rather than because some of the questions are totally Western specific, which we are not much relevance in India. So we are developing the questionnaire. Probably in a year's time, we will be able to publish it. Sandeep, you were saying something?
Yeah, Sandeep, we have switched to the SF36 and the SF12 questionnaire, because see, we have the same problem that KCCQ initially used to give us permission to use freely. Now they became actually very pricey, and it's not possible to buy such an expensive question. SF36 and SF12 are free. So if you're doing face-to-face, you can use SF36, which is actually almost similar to KCCQ and as good. And if you're doing it across the phone, SF12 has actually very few questions and seems to be as good, and they're free. And see, they are validated questionnaires. So you don't have to start validating the questionnaires.
Yeah, this questionnaire is a very difficult process. You have to linguistically validate, you have to culturally validate. Then it is a long process. It takes months and months to develop a questionnaire, actually, first to translate, retranslate. It's a big process.
That portion you've done the translation, retranslation. That portion doesn't take much. That portion you've done.
No, the new questionnaire which we are developing,
that obviously
should be for all the states, no? So that will be.
Dr. Sandeep.
Finding SF1236 seems to be a very simple way to.
Maybe you can use that of SF36 and modify it according to your Indian requirements. Hari?
Yeah, we are including SF36 also, because we have to include many aspects. So we thought we will have a comprehensive questionnaire on all aspects like compliance, all aspects of daily living in patients with heart failure.
Also, to be practical, it should not be very lengthy also.
Correct. That is what we are trying to make it as shortest as possible. Yeah.
Maybe we can have two versions, one is a short version and a longer version.
Yeah, maybe we have to. We are thinking in that line also. Yeah.
One short version for example, teleconsultation. Just
and
5
the
days.
Longer one, longer one for research purposes.
Collection and research.
Correct. Yeah.
Dr. Negi, I have a question for you.
Yeah. So we have one. Yeah. Go on, Dr. Negi.
Dr. Sandeep, how many the patients do you have in each heart failure clinic day? How many patients do you see?
About 50.
50.
50.
And how much time does it take to provide all these education, parameters?
I have 2 rooms there. So I sit in one room, and in the other room, I have a physiotherapist coming turn by turn. I have a heart failure nurse and I have a research fellow. So they will fill in the checklists. Some of the patients will be taken to the yoga room for physiotherapy. And after all the checklists are done, counseling is done, and all the medication lists are made, ultimately after all that, the patient will come to me. So 80% of the work actually is done by the other people. I do only 20% of the work. That's why if you saw the picture, the doctor was only a small component of that heart failure clinic. So I'm a small component of that heart failure clinic. That's how I'm able to see 50 patients.
So there's something I think it's reasonably resource, you need manpower, resources, space. I think these are some of the limitations which we have, at least in our medical college in IGMC. I was thinking we started long time back, but we could not continue because of the lack of space, because we run the routine cardiology OPD and we thought initially we'll start the heart failure clinic in the afternoon. So, but the morning OPD goes on till the afternoon, so there is no space available for running the heart failure. So all these clinics which we thought initially, like coronary clinic, heart failure clinic, we will run, we started because of OPD. So I think we thought initially we'll start the heart failure clinic, so there's no space available for running the heart failure. So all these available for running the heart failure. So all failure clinic, we will run program, unique patient education, diet, physiotherapist, titration of the dosages, monitoring of the parameters. So each patient, I'm sure, so for that you need a the group of at least team. So for that, available manpower to start the program would be very difficult. I just want a comment of Dr. Harikrishnan because of the national activities going on. Can we think about as a part of sub-study doing this kind of a quality initiative program, improve adherence to medication, modes of guideline-based medication, the dose which they need to be on, because most of the study shows that basically the use of guidelines-directed medical therapy is poor, and on the drug dosage which these people get are much lower than what it should be. So there's a lot of gap. That's why the mortality, the outcome is poor. So as a part of sub-study of the national heart failure, can we think about submitting some kind of a sub-study implementing this kind of quality initiative?
Yeah, we have the plans to, because we are recruiting another 5,000 more patients in the next stage of the National Heart Failure Registry. But one good thing is that in Trivandrum Heart Failure Registry, it was only 25%. The National Heart Failure Registry has become 42% of the guideline directed therapy. So there is a significant improvement in the prescription of heart guideline directed therapy over 7 years, because 2013 was the Trivandrum registry. So 7 years, the physicians' prescription have improved to some extent, but not adequate. We have more scope of improvement. So in the next stage of the national registry, we will be doing one of the quality improvement initiatives.
The Asian Heart Failure Registry.
I think the second important part is that the dose which we are using, those are usually suboptimal, because I've seen what it should be. So there's a lot of gap which our colleagues also, even if the pressure, humanity patients are stable, say systolic blood pressure 110, and they are tolerating well, they have no symptoms of postural hypertension, but tendency of stepping up the RAS beta blockers are usually suboptimal.
Yeah. Yeah, the dosage, we are not achieving the target levels in most of the patients.
Okay, Dr. Tiny, there are two questions for you in the chat box. One, I say you may take it because you talked of a transition and trials like that. So Dr. Asha Murthy, she wants to know that a heart failure patient on ARNI develops hyperkalemia. And if he develops hyperkalemia and starts vomiting, is it possible to stop ARNI and start DAPA in such a patient? What is your thought on that? Unmute, please. Unmute yourself.
No, I won't advise that, because one, a patient is vomiting and your DAPA is likely to dehydrate him more, So if there is hyperkalemia, first thing is try to stop MRA, because most hyperkalemias are because of MRAs and other drugs. And try to reduce the dose of your ARNI or RAS inhibition, whichever you are on, so that, and find out what is the underlying reason for his hyperkalemia, what is his GFR, and is there a reason, is he eating too much of fruits, or what exactly is their diet problem. And try to, most of the cases, if the kidney function is not too bad, you can escape and go back to the previous ARNI dosage. And in a background of hyperkalemia, I get your point, because, conceptually ARNI produces hyperkalemia, right? DAPA doesn't. DAPA, if at all, takes a fluid of the body. But probably that is not an, if you say that it's only my ARNI that is producing hyperkalemia, there is a point, right? It is, but most likely it might be your MRA, other drugs, or your bad LV, bad GFR, or some kind of diet that might
implementing this kind of quality.
The second, I think I can also read the second question by Dr. Asha here.
Ramachandran.
Yeah. I agree that the comprehensive prescription works better in cases of de novo heart failure, HFrEF in young patients. Can we do an etiological diagnosis like PPCM, ICMP, and chemotherapy? Yes, certainly. Now, when we are looking at, I was just talking on the challenges of heart failure management in COVID, but certainly when we are talking about any heart failure, especially young, we have to look for an etiological diagnosis. We have to rule out ischemia. We have to rule out specific cardiomyopathies like alcohol, peripartum cardiomyopathy, because each one of those has a specific set of therapies, right? And they might improve the patient out of it. So we have to make an etiological diagnosis. That is no question. But basically, when it boils down to heart failure management, we are talking about those standard treatments of beta blockade, RAS inhibition, MRA, and of course, depending on whether you want to go for a CRT or amitriptyline or whatever it is. And of course, now that we have got SGLT inhibitor, dapagliflozin. So I think etiological diagnosis is very important, and we have to do that.
Right. So we are almost towards the end of our symposium. We've got about 3 to 4 minutes to go. So as mandated, quick last minute comments from Vishal, then Dr. Negi, and then Dr. Hari Krishna and Dr. Vijay Chopra, please. So Vishal, your comments, final concluding comments, please.
I think both the topics were very nicely discussed. Just one comment that I have is that these heart failure treatments are not a replacement to one and the other, as has been probably suggested in one of the questions here, that dapagliflozin and SGLT2 inhibitor, for that matter, and ARNI, they are not, they should not be used as a replacement of one to the other. Ideally, the patient should be on all these pathways treatment, and that's how we should look at it. If the patient has any reason to discontinue any of the treatment, that's all right. But then we should not think of that stopping one treatment and then starting the other line of treatment. Dr. Sandeep also very nicely explained, what we can achieve and how can we start a heart failure clinic, and then its benefits. These have been 2 wonderful talks. I thoroughly enjoyed and learned a lot today.
Thank you. Dr. Negi Saab, your final comments, please.
I definitely do agree. There definitely role of heart failure care program is established in the form of establishing the cardiac clinic in order to improve the use of guide-directed medical therapy and optimization of dosages in order to decrease the morbidity and mortality. But how it can be implemented with the limited resources, that needs to be seen. We need to use a technology-based, maybe telephone-based monitoring these patients at home. And as suggested by Dr. Tiny, recording weight, blood pressure, pulse, these are some of the important vital clinical signs which we take into account in titrating the dosages and keeping the patient stable, and ensuring the adherence to medication is definitely an important intervention. During the COVID time, I think we need to use more of telephone-based and maybe teleconsultation-based monitoring to reduce the morbidity as well as the mortality because of the access to the health system. I mean, the talks were really educative and thought-provoking, and we need to think about some innovations in how we improve the care of these patients. Thank you.
Thank you. Dr. Hari Krishna, maybe some concluding comments?
Yeah, so I will anyway I thank all the speakers, the moderators for this session and all the sessions, and this is the last session of this course actually. And I thank all the speakers have done a wonderful job, and we got excellent feedback on the course. And I request the participants to give their feedback on the course, whether we have, because we will be doing these courses in future also, because this is only a beginning, because now the online platform has proven itself as a way of education. And these physicians courses are very important to improve the quality of care in heart failure patients, where there is definitely a scope in India, as we have seen from these registries. So I request the participants to give their feedback, whether we should add more topics or we should discuss something more. And we have a very important post-test, which is just on. We had a pre-test. This post-test is the evaluation point of this course. And there are 25 questions. And if you answer 20 questions, you will get the certificate. But you can take the retest any number of times to get the 20 questions correct. But these are all simple questions which we have all discussed on guideline directed therapy, on fluid management, weight, daily weight measurement, etc. Simple questions, and all the explanations are given at the end of the question, the answers itself. So, so everyone, please take the test, and the certificates will be reaching you by post, or the Servier people will be sending you the certificates. And I also thank my people in Heart Failure Association, Dr. Chopra, Bagheera, Duday, women who were the backbone of this program. And I also thank Servier for giving this an unconditional educational grant and the support they have provided throughout the course. Thanks everyone, and I ask Dr. Chopra to say the final words.
Finally, before we close, Dr. Chopra sir, words of wisdom from you, and we close.
I think this was another great session, just like the previous 5 sessions that we have had. I have learned a lot. You know, all of us think we know a lot, but when you sit in these sessions, we all realize how little we know. At least that is what I felt. And it has been a great learning experience. Kudos to the team, and especially Hari, who has worked tirelessly. He's put together the whole program. And Hari, we are not going to leave you alone. We have some more programs lined up. This certification course is probably going to be done twice a year. And in addition, we also plan to run nurses training, or possibly a certification course, if we are able to convince the Nursing Association of India. That's another project that Hari has in mind. Because as we learned, nurses education plays a very significant part. And Dr. Sandeep Seth has been in the forefront in educating. He's run several programs for Heart Failure Association of India in every meeting to educate nurses. Apart from that, let's see if we do something for DNB students or so on and so forth. These are evolving programs. So please do send in your suggestions. I think this COVID time has, kind of brought out these Zoom meetings quite a lot. And we have also learned that we can reach out to a lot more colleagues through these meetings at a far, far lesser expense. Otherwise, if you hold a 200 people meeting, imagine flying so many people in, putting them up in a hotel and so on and so forth. So these are low cost initiatives, but I think they have a potential to a lot of good.
One more thing I wanted to say is that all the 6-day sessions are recorded and is available in the platform until August 5th. And the post-test also will be available till 5th of August. You can access that and the sessions every time. And the PDFs also, we have provided some study material like the guidelines from different associations. So that will be available to all the participants till 5th of August.
Wonderful. Thank you. Thanks very much.
I think we'll finally close the session now, sir.
Yes.
Thank you, everybody, all the moderators, speakers, and participants. Thank you very much.
Thank you.
Thank you.
Thank you.